Hello, welcome to another session of Zooming Through ID. I'm Dr. Gopal, an infectious disease specialist here in South Florida, trained at Duke University, been practicing for more than 22 years. I am the medical director here for Broward Health North Infection Control, and I am the chair for stewardship for the four Broward facilities. We have a infectious disease fellowship program. I'm the APD for that, and I'm also a faculty for internal medicine residents. So when the internal medicine residents rotate with me, they either pick a topic of their interest or we assign them a topic. And this is a um, platform where they showcase what they have researched and learned. So today's presenter is Nicole. So Nicole rounded with me, and we had an interesting conversation about Naegleria Fowleri. I was just talking that we had a case that was clinical presentation was consistent with that. And then the lab called saying that there may be potentially, this would be the potential case, but it turned out to be a false alarm. But being in Florida, this is something very important topic. So this topic, then Nicole hashed down to that topic and she wanted to present this. And this is a very, very rare condition. And usually most of the summers, this will make headlines into the newspapers, the brain-eating amoeba. And this is a devastating pathogen. Very few cases all over the world has happened, proven cases, and it's very important to know. And it is common we through the lakes, rivers, the fresh waters, and pools. The exposure happens. So Nicole is going to talk all about it, and I'm going to introduce. I mean, I will let you take over, Nicole.
Hi, everyone. I'm Nicole. I'm a PGY2 working at Broward Health North. I had a very fun time rotating with Dr. Gopal. I'm super interested in ID, so it was really nice getting to sit with her, get to know her, and hear all of her interesting cases. She showed me a lot of crazy cases that I've never thought I would ever see. I thought I'd only read them off a textbook, but I got to see them. So it was really nice to be involved in that. This is a topic that I really found interesting. I have this huge passion for a lot of parasitology, microbiology, and I think it's important. This is something, we're in Florida, so it's something that I think people should know about. So let me go ahead and start sharing.
That's awesome.
All right. So
Perfect.
Naegleria Fowleri, okay. So what is Naegleria fowleri? So this is what we call the brain-eating amoeba. It's a free-living thermophilic, meaning it likes the heat, protozoan, and a type of one-celled organism, and it thrives in warm freshwater lakes, rivers, hot springs. And as Dr. Gopal was saying, it's a rare thing to see, but it does lead to a brain infection that's almost always fatal. So hence the name brain-eating amoeba, just because it has the ability to infect the brain and destroy it. So the life cycle of Naegleria fowleri is three stages. You have the trophozoites, flagellates, and cysts. The trophozoites are long and slender. They measure about 22 micrometers in length, and they have these pseudopodia, which are like these little foot-like projections to help them move and to help them ingest. They are also capable of forming large colonies, and it's in this stage where you see the reproduction that leads to the human infection. And what's crazy about this is that when it's under poor nutritional conditions, these trophozoites will transition to flagellates. And if unfavorable conditions persist, then they'll become into metabolically inactive cysts that measure about 7 to 12 micrometers. And these cysts are resistant to low temperatures and will remain viable during the winter. So this protozoan has a way of just surviving during these harsh conditions and coming back to life when it needs to. These trophozoites feed on bacteria and fungi in warm waters, and they can insist and settle into sediments when water temperatures become low during the winter. So this is just a picture of the organism in the different shapes and forms, okay? And this is more so the life cycle of this organism. So usually, when individuals go swimming in like these areas, like the warm springs, all these things, um, this amoeba has the ability to go up the nose through this the cribriform plate, goes up the fibers, and it migrates to the brain via the olfactory fibers. And it leads to something called primary amoebic meningoencephalitis, or we call it PAM. And I'll remind you guys it'll be PAM throughout the video, just because it's a tongue twister. Um, so the trophozoites are usually the ones in CSF, and you can sometimes have the flagellated ones occasional in CSF. So when in water, this organism infects humans or animals in its trophozoite form, and again, it penetrates the nasal tissue, migrating to the brain through the olfactory nerve, and it crosses that cribriform plate and starts invading the central nervous system, causing the primary amoebic meningoencephalitis. So, the pathophysiology with this amoeba, it causes this robust innate immune response, and its virulence is modulated by a couple pathogenic determinants. So this is something including the NFA1 protein, nitric oxide production, and pore-forming proteins. The NFA1 protein plays this critical role in mediating amoebic adhesion to these host cells, while specialized feeding structures enable that organism to ingest environmental bacteria and fungi and directly phagocytose neural cells. And additionally, Naegleria fowleri contributes to extensive tissue damage through the secretion of cytolytic factors. So, cytosine proteases, phospholipases, and phospholipotic lipolytic enzymes, which drive this widespread necrosis. So now all of this happening with the host's immune response, this basically causes a substantial destruction of the brain parenchyma, and it leads to the rapid progression of this primary amoebic meningoencephalitis, PAM. So we're going to be referring this to PAM going forward. Um, so signs and symptoms. So the incubation period is about 1 to 14 days. Some of the early symptoms you'll see is like fever, headache, lethargy, nausea, vomiting. A lot of these symptoms mimic bacterial meningitis. So as this disease gets goes on moving forward, it becomes more severe and more clinical manifestations occur like confusion, nuchal rigidity, photophobia, which is like the fear of light. They develop seizures and cranial nerve abnormalities in a lot of the cases. So this happens very fast and it leads to either comatose and eventually death within a very small amount of time. So exposure risks are exposure to fresh water during the summertime. It's one of the key historical clues. One of the things that's very important about infectious disease that we were discussing with Dr. Gopal when I was rotating with her, you have to really know locations of where these infections occur. You have to know during the time, which temperatures, what time they're more prominent in. So this is one of the interesting ones where it's fresh water and it has to be during the warm time. So, geographic distribution. So, Naegleria fowleri, it thrives in warm, freshwater environments and it grows up into temperatures up to 45 degrees Celsius. It's found in soil, lakes, hot water springs, and rivers. And it can even persist in inadequately chlorinated bodies of water like wastewater, tap water, and even the swimming pools. So, yes, the infections are rare, and most of the cases in the United States have been seen in the southern states. So, in this case, Florida and Texas. And these infections tend to peak in the summer due to the warmer waters. So, this has to be diagnosed quickly. The only downside is that it's only a very few amount of laboratories and worldwide areas can test for this amoeba. And even when specimens are sent to the reference labs, the disease progresses too quickly for even the results to come out and to even be useful. If CSF is obtained, which is a cerebrospinal fluid, several diagnostic tests can be used to identify Naegleria fowleri, and a quick method involves visualizing the trophozoites. They use a wet mount. Other staining techniques like Giemsa, rye, hematoxylin, and eosin and periodic acid shift can also be utilized. PCR can detect it directly from CSF, and it's actually considered the gold standard for PAM diagnosis. But PCR limitations include limited availability and the necessity of clinical suspicion. Gram staining in standard bacterial cultures are unreliable, and just because the fixation process can destroy the amoeba. Antigen detection via immunohistochemical staining can also be performed on CSF samples. Additional diagnostic techniques for tissue samples that'll include immunohistochemical staining, indirect immunofluorescence, PCR, and culture. Serological testing is just not as useful just because the disease progresses too quickly before any results come out. MRI can provide some insight, but a lot of the findings are often they're non-specific in early stages. And at times, an MRI may show diffuse hemorrhages, infarctions, or contrast enhancement in the infected areas that the infection is thriving in. So, a brain biopsy, if feasible, it can provide definitive evidence of this, but it's so invasive. Histopathological examination typically will reveal hemorrhagic meningitis within the base of the brain and olfactory bulbs being the most severely affected areas. Normally, once they get this sample, they'll see numerous trophozoites within the necrotic meninges. So these are the different treatment modalities. Amphotericin, or we say amphoterrible, just because it causes so much side effects. It's used widely in a lot of systemic fungal infections, and in this case, this amoebic infection. So there's the IV route, intrathecal route, and there are different courses and duration of days for each one. So it's important that if you suspect this infection, to get your infectious disease doctor involved. In this case, we would get Dr. Gopal. Um, so amphotericin, azithromycin, these are all the doses here. Let me see if I can move this. And then the different courses. And this is another one. Posaconazole is another option that could be utilized. Um, Here are the different dosages for the adults and for the children if infected. And here's another couple of treatment modalities. Dexamethasone is one we use commonly just to help bring down inflammation in the brain. We have rifampin, meltefosine, and nitroxyline. So this is one that you also have to contact the CDC for dosing. So the prognosis is often fatal. It leads to severe cerebral edema, hemorrhagic necrosis, and increasing intracranial pressure, eventually leading to brain herniation and death within days of the symptom onset. Other complications will include seizures, cranial nerve dysfunction, hydrocephalus, and comatose. So 98% mortality rate. A lot of the patients end up succumbing despite even having treatment. Survivors may experience neurological deficits, but recovery is often rare. Early diagnosis and prompt initiation of therapy are critical in preventing fatal outcomes and minimizing long-term complications. So, this is a fact sheet campaign that was previously on the CDC website. It was discussing about 2010 from 29 to 2019 how 34 infections were reported in the US and only 3 cases were able to survive. Um, and it gives a little infographic, symptoms that are noted, infections and how they're passed through the nose, and how infection isn't occurring by drinking contaminated water, and how the infection cannot spread from one person to another. It's not like, let's say, I sneeze on Dr. Gopal, she's not going to get it, which I would never sneeze on her. So there's another one that we like to compare it to. It's called Balamuthia bendralaris. Sorry, it's a mouthful for me. So these two comparisons, one causes GAE, which are slower granulomatous tumor-like lesions. This one takes about a couple weeks to months for it to kill its host, whereas Naegleria fowleri causes 1 to 7 days. Um, Naegleria fowleri tends to affect healthy children or young married adults who swim in warm water just when they're on vacation, in a sense. Whereas this Balamuthia often infects, but not exclusively affects immunocompromised individuals. This also enters not just through the nasal mucosa, but also through skin lesions. So this has a better chance of infecting its host. Now, it does present with the same neurological deficits that often mimic a brain tumor, and it can include skin lesions before involving the brain. This is just a picture of how the lesion looks. Okay. Now, we always do a couple board questions, just to test and see how good were you listening. So, question number one, a 10-year-old boy is brought to the emergency department with a 3-day history of severe headache, fever, nausea, and vomiting. So, a lot of very non-specific symptoms. It's good to get a history from everyone that's been around the individual. His parents note that he has become increasingly confused and irritable. And the patient was swimming in a warm, shallow freshwater lake in Florida about 5 days ago. So again, there's an emphasis of knowing how long ago this patient was swimming in this pool of water, where they were doing this. So it's always important to ask about travel. So CSF analysis shows high neutrophils, elevated protein, and low glucose, but no organisms are seen on that gram stain. What is the most likely causative agent? So in this case, Naegleria fowleri, just as we discussed prior. Cryptococcus neoformans is usually something that you see in immunocompromised patients. Entamoeba histolytica usually it's a type of parasite that can cause bleeding. And Toxoplasmosis gondii, again, it's one of those things I've more commonly seen in immunocompromised patients, such as HIV patients, with very different symptoms. Now, question number two. A patient is suspected of having primary amoebic meningoencephalitis. Which of the following is the most appropriate next step in laboratory diagnosis? Do we culture the blood, perform a urine antigen test, examine cerebrospinal fluid for motile trophozoites, or test for serum antibodies? So in this case, we would take a look at the CSF. Blood cultures are not the way to go for this just because it's in the brain. Um, no urine antigen test has been made for this. Again, it's in the brain, and there's no serum antibodies to test for this. So next question, a 35-year-old male presents with symptoms of meningitis. The patient mentions using a neti pot for sinus irrigation, using tap water rather than distilled water. The patient dies 3 days later. Which of the following is the most likely route of entry for the causative agent? So basically, it's asking, how did this patient get? We're asking which organism it is. You have to think about it first. So in this case, Naegleria fowleri. And as we discussed, this guy is utilizing a neti pot. So we know that this amoeba travels through the nasal mucosa, through that cribriform plate to get up into the brain. Okay. Now, these are my references, and I appreciate Dr. Gopal for having me here today. Thank you so much. It
Awesome,
really,
awesome
yeah.
presentation, Nicole. This is excellent. So you touched upon all the key points. So this is one of the cases where the history is crucial. It can present like a neutrophilic meningitis. In most cases, we may think it is bacterial. So the key history is the swimming, the freshwater exposure, and this is very lethal. Mortality is very high, and this is one of the cases where we have to call the lab and alert them and ask them to. So, like you mentioned, uh, very limited. We don't have a whole lot of case reports. So the treatment is mainly extrapolated from limited information that we have. So kind of throw in whatever we can on the patient, try to save the patient. Miltefosine is available from CDC, so immediately we have to call CDC, alert the lab, alert everybody, and very high mortality, and action is needed quickly. Prevention, it's very hard to prevent. when one of the aspect is swimming in warm water, maybe put the head above the fresh, warm water. It's not easy. Easy is sad, but it's not easy to do it. And then there is a practice to nasal rinse. There are people who do nasal rinsing, so it has to be only boiled water, distilled water, not just tap water. So that's also one other prevention. So very interesting, and I saw that the difference between the Belamotria and this is Belamotria that immunocompromised patients. This is like healthy patients, and it is something that is very, very important that everybody knows. And this was an awesome presentation, fantastic job as always, and it was a pleasure to have you. Thank you
Thank
all for joining.